spastic with increased muscle tone and stiffness, is kinetic with involuntary movements, ataxic with poor coordination and poor balance, and a mixture of these. It's important to understand how these things look like because of how the initial insult or injury or malformation comes about. In the spastic type, we are talking about a part of the brain where the nerve fibers from the cerebral cortex travel to innervate the muscles. And this area is the periventricular area. And you can see here a normal brain. The ventricles are in the middle here. And the white matter very close here contains all the tracts and the various movements of the nerves. And so if you have damage to that area, like you can see in the second image here, you then damage the motor tracts. And so you have basically an upper motor neuron lesion where the muscles are not getting direct instructions. And so they are very spastic or increase in tone and stiff and have spasms. And the control is not there from the voluntary part. And that's what gives rise to the clinical picture that we know about. The dyskinetic cerebral palsy has to do with lesions in the part of the brain called the basal ganglia, which help to refine how the signals are perceived and how they are transmitted from the cerebral cortex to create that smooth and coordinated motion and movement and controlled movements. And so when you have lesions here, then you lose that control and that fineness and that, and also,
Hello, Michael,
yes,
please,
can
can you speak up a little louder? We can hear, but we just want you a little louder.
Okay.
Thank you. That's good.
Let me, yeah, okay. Maybe I turn this up a bit. Just a second. I think it's on. Okay, I think I just increase the volume because this seems to be okay. Right. Can you hear this better now?
Yes, it's better.
Right.
Thank you.
Okay. So I was talking about this kinetic cerebral palsy where the lesion is in the basal ganglia. And the basal ganglia are the part of the brain that help to control the impulses that are coming from the brain to the muscles to coordinate and to control those signals to create smooth movements, coordinated movements, and so on. And so they kind of refine the motor signals. They also help in learning procedures and habits and so on. And also in learning. And so when these are damaged, then you get the clinical picture that we see leading to movements that are not voluntary, dystonia and dance-like movements and movements that are not as intended. And then the third is the ataxic, which has damage to the cerebellar aspects of the brain and the brain stem, the cerebellum and the brain stem, which is responsible for coordinating voluntary movement and balance and posture and so on, so that one can kind of walk in a straight line, if you want to simply put it. And so damage here leads to the problems with balance and tremors. And of course, the mixture of the three. cerebral palsy or CP has a worldwide prevalence of about 1 to 3.5 per thousand births. And so that makes it quite a common motor lesion group of diseases. Now let's go into the causes. We've seen where the lesions are, but what can cause lesions in these anatomic spaces that we have mentioned? The lesions could occur prenatally or during the pregnancy or during the delivery or in early childhood. And many times it's not really easy to detect what the cause is, and there may also be multiple factors. So let's look at some of the causes. In the antenatal section, we have the genetic factors, and a few genetic things have been pointed to that affect brain development. The BFPP gene mutation causing some brain malformations, an autosomal recessive condition, ataxic cerebral palsy, and then the TRPM3 gene mutation, which also affects the brain. These are not the commonest reasons, but they are important also to understand, especially when it comes to the counseling aspect and so on. Maternal infections are important because a lot of these things sometimes are not very much under the control of the parent, and that can be a challenge and can affect the baby. Stroke in the perinatal period from in utero to 28 days after pregnancy can also lead to some of these situations. Even during the pregnancy, there could be strokes or blood clotting issues, heart defects, and abnormal blood vessels that could bleed, especially in the brain, and then cause some of these brain challenges. During birth, the challenge of maintaining oxygenation can be the problem. Placental causes, either the placenta separating or the placenta not getting adequate blood flow and therefore causing low oxygen levels to the developing fetus. Umbilical cord accidents could happen, like cord prolapse, and many times we've seen true knots in the cord and so on, which can be a challenge. Also, where you have severe maternal challenges leading to very low blood pressure, like in the uterine rupture and so on, they can lead to severe lack of oxygen in the baby. Trauma to the baby could also occur either as part of labor or part of the interventions that may be put in place. Okay, I think somebody is joined on the screen. Was that me? Okay, and after birth, which is not as common but possible, brain damage in the first few months of life, severe jaundice, not treated, we've seen that. Infections of the brain, meningitis, encephalitis could also cause this. Problems with blood flow in the brain, like the strokes I mentioned earlier, blood clotting problems, and abnormal blood vessels. Also, brain injury after delivery from falls and accidents and child abuse could also, in rarer cases, lead to this situation. The table that I show here shows an attempt at looking at what the causes of the cerebral palsy in a number of children are, taking 34 quadriplegic and 116 non-quadriplegic cases Congenital disorders, 53% in the quadriplegic and 35% in the non-quadriplegic. Birth asphyxia being of a smaller order of 14% and insignificant in the non-quadriplegic. Other disorders being minor and unknown, being as much as 60% in the non-quadriplegic group. One of the biggest factors that can lead to some of these causes is premature delivery, premature or low birth weight babies. And they are at a much higher risk of developing cerebral palsy. And you will see that a lot of the interventions have to do with avoiding prematurity or reducing it as much as possible, and low birth weight as well. 50% of children with cerebral palsy born prematurely, and those that are much smaller, 1,500 grams, 30 times more likely to develop this than full-term infants. And even those who were born before 28 weeks, 10 to 15% having CP. But why is this so? It has to do with the pictures I showed earlier of the brain hemorrhages and the periventricular leukomalacia, which occur more with the premature and low birth weight babies due to the fragile nature of their blood vessels, and so they easily bleed and cause these problems. Also, the lack of oxygen can also lead to damage of the brain as the blood supply is reduced, and so we need to really look at that aspect. Chorioamnionitis, maternal temperatures above 38 degrees, and even infections just after delivery can lead to more inflammation in the brain and affect the neural connections, damaging them and giving these lesions that we have spoken about earlier. And then also respiratory distress problems leading to more interventions like oxygen and intubation and CPAP can then put in some of the risks. So let's look at the risk factors also in group. For very simply put in this slide is being too small, coming too early, being too many at a time as in multiple pregnancies. Some studies have shown that being conceived via assisted reproductive treatments or technologies also puts the babies at risk. Not because of the procedure itself, but because these pregnancies are more likely to be complicated, either because of the number of babies or because of the comorbidities in the mothers.
Hello, Michael.
Yes.
Sorry. I'm very sorry to interrupt you, but I just need to give them an announcement. Please,
Sure.
kindly stop putting your license registration, MDC registration numbers into the chat box. It's going to clog the questions. There's going to be a link where you can put in your number, and then we'll give you your CPD points. So please stop putting the numbers into the chat box. Thank you.
Okay. Right. So low birth weight is one of the risk factors, and being born preterm prematurity is the problem. Increased risk in multiple gestations, and I've already mentioned the assisted reproductive technologies and the reason, and of course being born in the environment where the mother has an infection. So antenatally, maternal conditions, comorbidities like diabetes, hypertension, also lead to premature deliveries, and that can then become a challenge. I think we've mentioned these already as risk factors around delivery, and then those after delivery, we have mentioned also. So let's go on to the preventive strategies. We want to, as much as possible, increase the gestational age at delivery so as to avoid the risk factors and therefore escape the causes of CP. And there are a number of interventions that have actually been proven and show that we can actually reduce some of these challenges. So I'll just take them one after the other. Magnesium sulfate, we use in two ways. One is to stop uterine contractions in preterm labor for tocolysis, and the other is for neuroprotection. The dose is similar, but if we're using it only for neuroprotection, then we are using 4 grams IV over 15 minutes, and then an infusion of 5 grams in 500 mils at about 100 mils per hour for 24 hours. And that then constitutes the neuroprotection. Practically, we sometimes have to use magnesium sulfate plus magnesium sulfate also for tocolysis. We may need to use higher doses for the maintenance infusion to be able to suppress uterine contractions and then sustain this over 24 hours. So we are able to use the magnesium sulfate for both the neuroprotection and also the tocolysis in a dose that is acceptable for both. We can also use nifedipine as a tocolytic agent to stop contractions. The second thing that we do to intervene in this case is to use antenatal steroids, which help to reduce periventricular leukomalacia, accelerate fetal lung maturity, and some of the other complications of the premature infant. And this should be administered as early as possible. One needs to be extremely proactive in determining which babies, which mothers would need this, and not delay in administering the antenatal corticosteroids. It's not given prophylactically to everybody, but only when there is that need, because as we know, there are also side effects and complications from this. The other part of preventing preterm birth is to use prophylactic or emergency cervical cerclage or prophylactic progesterone, vaginal progesterone administration to delay delivery. And this is really important to have a very high index of suspicion and very high monitoring, especially between 16 and 24 weeks, monitoring the symptoms, monitoring the cervical length, of course, after the history, a very good history, and knowing the previous outcomes of those pregnancies. But monitoring the cervical length is very important. the cervical length should be more than 25 millimeters. And if you see progressive shortening or you see a length that is less, then that calls for intervention. And these interventions are not very complicated, and so they can easily be applied, and we do not need to hesitate from using them. And they actually do work very well. Preventing infections in the situation of preterm premature rupture of membranes is also important, with oral erythromycin once the diagnosis is established. Vaccination against preventable infections in the prenatal period before conception is also very important. And of course, regular antenatal checks to pick up some of these other issues early on. Perinatal and neonatal care, looking at the early detection of neonatal jaundice, I think this is really important. Early detection, proper measurement, and appropriate application of phototherapy is really important, and that can really prevent the brain damage from excessive exposure to bilirubin. This must be a case that is really severe. It's good to think about G6PD deficiency. I remember the case I saw was a child that had G6PD deficiency and suffered severe neonatal jaundice and ended up with some form of cerebral palsy. And so that's a very important thing. You realize that when the mothers are coming to the clinic with their items, they have camphor balls, naphthalene balls in their bags to ward away insects. And if there is G6PD deficiency, this can actually become a very big challenge for the child, the neonate, and may even cause this. Neuroprotection, also important. And there's a description of moderate hypothermia for infants who suffer HIE. I'll leave that for Dr. Hammond to discuss. Also, avoiding unnecessary oxygen, because that could also lead to some complications if the oxygen therapy is too high or too prolonged. And also managing hypoglycemia in infants. And so we have the protocols of how to monitor hypoglycemia, when to check for hypoglycemia, which babies need to have screening for hypoglycemia after delivery, and so on, so that we can pick hypoglycemia before it stays for too long and before it can cause damage. And I believe now glucometers are very easy to come by, so that shouldn't be a big challenge. But having the protocols and having the system to actually get the tests done just after delivery for the children, the neonate, is really important. Prevention of head injuries is also important. Car seats, child abuse, or shaking the child or throwing the child up and creating forces that can damage the different parts of the brain can be a real challenge. Recently, we have seen a lot of, not a lot, I'll say an increasing number of women who are using tobacco and other drugs, like Indian hemp and so on, and other medications for recreation or drugs for recreation. And it is actually a cause for worry, much more now than it was maybe 10 years ago. And I think that is challenging. Secondhand tobacco smoke, I keep seeing it, especially in women who work in other environments where the people there are smokers and they don't have the social power to either stop work or move out of work. And so these things are actually very real for our mothers. So I'll end with the mothers. The important actions that the mothers can take are to ensure antenatal screenings are done so that we can identify the various things. You tend to see that women who have had a number of children don't take the antenatal periods as diligently as the one who is coming with her first pregnancy. But that could be a challenge because the risk factors may be higher in the one who has had more because of age and comorbidities and so on. Ensuring that we avoid infections is really important. Toxoplasmosis is something that also occasionally we see and can be avoided by proper hygiene. Maintaining a healthy lifestyle generally during pregnancy is really important. And it's not out of place to have to visit the dietitian as a pregnant woman to be able to get a grip on nutrition in pregnancy, which we know is quite challenging and not the same as nutrition outside of pregnancy because of the various factors. Women frequently ask me about exercise during pregnancy. And yes, you can have exercise during pregnancy, and there are safe exercise that one can do: walking, swimming, aerobics, dancing, and so on, which can really be helpful to increase blood flow. Managing existing health conditions is key, especially high blood pressure and diabetes, which can really be a challenge. One of the diseases that sometimes we do not take cognizance of is thyroid disorders, which may not be as common as diabetes and hypertension, but we have a number of pregnant women with thyroid disorders. And this also needs to be controlled well so that we don't have these pregnancies ending early, therefore putting the babies at risk of CP. So at this point, I will pause, and then if there are any questions subsequently after Dr. Hammond's presentation, I will be very happy to take those questions. Thank you for your attention.
Thank you very much, Dr. McCarthy. Thank you so much. This was very insightful. We will go on to have Dr. Hammond to give us the overview of cerebral palsy. We will not take questions now. When Dr. Hammond is done, then we'll take the questions as a whole. Please remember that there's a link in the chat box. It's a Google link, Cerebral Palsy CME CPD form. You can fill this with your details so that you can get your CPD points. Thank you very much, Dr. McCarthy. Dr. Hammond.
Yes,
The
thank you
floor
very
is
much.
yours. Yeah.
And thanks again to Dr. McCarthy for setting the tone for my presentation. Please, Marilyn, can you confirm if you can hear me?
Yes, we can hear you loud and clear, and we can see your slides. Yeah.
Yes. So, yeah, that was a very good presentation from Dr. McCarthy. And actually, he's touched on many of the things that I was going to talk about. So it will make my presentation brief. So I intend to talk about these things as we go on. And Dr. McCarthy actually defined cerebral palsy for us excellently. I just want to re-echo that it is describes a group of permanent disorders of movement and posture resulting from non-progressive disturbances, and these disturbances could be injuries or insults to the developing brain. And when we say the developing brain, we mean the brain from conception
Hello,
let me say that
Dr. Hammond,
for
we lost you for
most
a while.
infants or most ones. Hello, yes.
We lost you for a while.
Oh,
Just a
okay.
few seconds.
Sorry.
Yeah. Okay.
Can you hear me now?
Yes, please. Thank you.
Yes. Cerebral palsy describes a group of permanent disorders of movement and posture. And movement and posture is very important. And it results from non-progressive insults or injuries to the developing brain. I was trying to explain what the developing brain is. And we are saying that it is the brain of the fetus up to about 2 years of life. And we are saying 2 years because usually by 2 years, about 95% of the brain has myelinated. Myelination is the process where myelin sheet is put on the neurons or the axons of the neurons. And it goes on for a very long time, sometimes into early adulthood. But we are saying that by 2 years, about 95% of the brain is myelinated. And so between that time from conception to 2 years, the brain is very fragile and it will easily sustain an insult if is subjected to such insults. And that is when most patients with cerebral palsy have their insults occurring. We are saying that although the injury in cerebral palsy is non-progressive, or it's a static insult, or in other words, it is a one-time insult, but the neurological manifestations evolve or they change over time. So usually when you have patients who have a sustained insult to their brain, we don't classify them as having cerebral palsy. And as a typical example would be hydrocephalus with increasing pressure. And because of the increasing pressure, there is always pressure on the cortical mantle and it gets smaller and smaller and smaller. This is an ongoing insult. It's a progressive insult, not a static insult. So such patients, you don't want to classify them as cerebral palsy. Because again, we are saying that for cerebral palsy, the insult is a one-time insult, a non-progressive insult. But remember that the manifestations evolve or they change over time. So cerebral palsy is basically a motor disorder, but it can be accompanied by many other neurological deficits, including disorders of sensation, perception, communication, cognitive behavior, epilepsy, and then sometimes secondary musculoskeletal problems. CP or cerebral palsy is the most common cause of physical disability in children. The global incidence is about 2.2 per 1,000 live births, but that is in well-resourced countries. In low and middle-income countries like ours, the incidence is even higher. We do not have a robust community-based data to tell exactly the incidence, but some clinic-based data have put the incidence between 3 and 5 per 1,000 live births. And we are saying that the manifestations of cerebral palsy is usually evident before 2 years. And as I said earlier on, there may be multiple comorbidities. I want to spend the next few minutes classifying cerebral palsy because they are all not the same. It is actually a heterogeneous group of disorders. But Dr. McCarthy again did very well in classifying for us, making my work a bit easier. But I'll still go through the slides anyway. So traditionally, cerebral palsy is classified. Some books will actually say cerebral palsies because we are not talking of one condition. They are classified based on the nature of the motor disorder, which is a tone abnormality, and then also based on the topographical or anatomical distribution. So based on the motor disorder, you may have a spastic cerebral palsy. where there is increased tone or there is spasticity. Then you may also have dyskinetic cerebral palsy, where there is abnormal movement. Dyskinetic or dyskinesia means abnormal movement. You may also have ataxic cerebral palsy, where there is unsteady gait, as you can see from the word ataxia, or they may be mixed. And I'll talk about that as we go on. If you look at the topographical or the anatomical distribution, you may classify cerebral palsy as quadriplegia, where all 4 limbs are involved. And please note that we are not saying saying tetraplegia. We are saying quadriplegia. We tend to want to use the term quadriplegia rather than tetraplegia in cerebral palsy. Tetraplegia is broad. It means all 4 limbs. But quadriplegia is specifically used when it comes to the 4 limbs in cerebral palsy. And then you may also have diplegia. Diplegia is when the 2 lower limbs are involved. In most patients with diplegia, all 4 limbs are involved, but the lower limbs are so severely affected that the upper limbs look relatively spared. So we often say it's the lower limbs that are involved, but actually all 4 limbs are involved, except that the upper limbs are relatively spared. Then you may also have hemiplegia, where one side is involved, and some very rare forms include triplegia and monoplegia. There are recent classifications that are a bit different from the traditional classifications. Some of them will use the gross motor functional classification scale, and then a lot of others, including communication functional classification system and others, but will not go so deep into that. Again, Dr. McCarthy did a very good job talking about the etiology and the risk factors for cerebral palsy. So I'll just touch on them briefly, and then we can then concentrate on the management. So the risk factors or the etiologies can be grouped based on the timing of the insult, and have grouped them into genetic risk factors, preconceptional risk factors, prenatal risk factors, perinatal, and postnatal risk factors. So for genetic risk factors, these include chromosomal syndromes and then single gene deletions or microdeletions that may predispose the brain to certain insults. Preconceptional risk factors, these are risk factors that are even there before the mother conceives. So they include maternal illnesses like seizures, intellectual disability, thyroid disease, and iodine deficiency. So if any mother has these conditions, we should bear in mind that she has an increased risk of having a child with cerebral palsy if she conceives. And then maternal history of stillbirth or neonatal death. In any mother who has had previous stillbirth or neonatal death, there is an increased risk of subsequent babies with cerebral palsy. And maternal age over 40, and then low socioeconomic status. These are preconceptional risk factors, even before you conceive. And then whilst you are pregnant, that's the prenatal risk factors. These include intrauterine infections. We heard a lot about rubella, CMV, that's cytomegalovirus, toxoplasmosis, and then others, including syphilis and herpes infections. And then even people have even mentioned HIV, but HIV is in a class of its own. Placenta abnormalities could also be a risk factor for cerebral palsy, and bleeding in especially in the 2nd or 3rd trimesters, and conditions like eclampsia, preeclampsia, chorioamnionitis, and maternal drug use, especially alcohol, cocaine, and tobacco. These are potential teratogens, and they can damage the brain of the developing fetus. Oligohydramnios or polyhydramnios, for whatever reasons, are risk factors for developing cerebral palsy. And then intrauterine growth restrictions, multiple pregnancies. Some babies may suffer stroke whilst they are still in the mother's womb. We call that stroke in utero. And we also have intracranial malformations from various causes. These are all preconceptional or prenatal risk factors, rather, for developing cerebral palsy. Now, perinatal risk factors, these are risk factors around the time you are being born, and they obviously will include things like fetal distress, difficulty deliveries, instrumental deliveries, breech delivery, prolonged labor, and by and large, these are the most common risk factors we encounter in our part of the world. Meconium aspiration and birth asphyxias, which will lead to hypoxic ischemic encephalopathy. And then sometimes birth injuries affecting the brain. And we see that most babies who suffer severe forms of cerebral palsy have multiple risk factors. So there may be prolonged labor, and then there may also be fetal distress, and then the baby is born with instrumentation, or sometimes even by emergency cesarean section. And then the baby now has meconium aspiration and then also birth asphyxia, and may suffer some birth injuries as well. So these risk factors tend to be multiple, especially in patients who have severe forms of cerebral palsy. Postnatal risk factors include prematurity, or being born too early or too small, low birth weight, respiratory distress syndrome from all manner of causes. It may be from hyaline membrane disease, maybe from other respiratory infections, maybe from pneumonia, or even from brain malformations. Also conditions like hypoglycemia, a very common but preventable cause of cerebral palsy in children. And kernicterus, we all know, leads to bilirubin-induced neurological dysfunction. And it's unfortunate that we still have a lot of babies suffering kernicterus, and the end result is usually not good. I don't know what PN Society, we have been drumming this home over the years, but only today I had a heartbreak in clinic when someone told a patient that when the baby has jaundice, they should expose them to sunlight. So I want to use this opportunity to say that, yes, the principle is good. Sunlight works the same as blue light that we use for phototherapy, but no new mother can stay in the sun for 24 hours. I mean, the maximum you can do is 30 minutes, and then you go back to your room. So we shouldn't keep asking mothers to use sunlight exposure to treat jaundice. If we think that jaundice is so severe or is pathological and requires treatment, let's admit these patients and then treat with phototherapy. It is way, way, way more efficient, because with phototherapy, you can do 24 hours. The only times you don't do phototherapy is when the baby is taken out of the cot for feeding or for diaper change or something. But we can always put the baby under phototherapy for 24 hours, as opposed to exposing the baby to sunlight, doing sunbath, which we can do for only 30 minutes or 1 hour. So we shouldn't continue preaching that. And I was so heartbroken when I heard that someone telling a mother that they should do that for their baby. And the end result was that the baby was seen today with this kinetic cerebral palsy, something that was very preventable. Again, neonatal seizures are a very common cause of brain insult or injuries in early life, up to 28 days of life. But even seizures beyond the neonatal period could be a source of cerebral palsy. So remember, we said that the insult or the developing brain is up to 2 years. Then infections like meningitis, encephalitis, cerebral malaria in early life, head injuries from all forms of trauma, and then stroke in early life, child abuse, especially shaking baby syndrome, and then also submersion injuries or drowning or near drowning. These are all risk factors for cerebral palsy in the older child, in the infant or the child up to 2 years. Now I want to talk about the forms of cerebral palsy. The most common form of cerebral palsy is spastic cerebral palsy. It accounts for about 70% of all the cases we see. And in spastic cerebral palsy, most of the time, the injury is to the corticospinal tract. That is the cortex. So let me just put it in simple terms, the cortex, or the corticospinal tract. And they usually present with delayed milestones, hypertonia or spasticity, hyperreflexia, seizures, intellectual disabilities. They are by and large the most common forms of cerebral palsy we see. Spastic cerebral palsy can further be subclassified based on the topography or the anatomic distributions as monoplegia, diplegia, hemiplegia, triplegia, or quadriplegia. The most common forms are quadriplegia, diplegia, and hemiplegia. Monoplegia and triplegia are not common. So this table tells us a lot about the common forms of spastic cerebral palsy. With spastic hemiplegia, the description is that only one side is affected. But you can see from the diagram shown in the table for spastic hemiplegia that the upper limbs are dense than the lower limbs. So the upper limbs are more severely affected than the lower limbs. So for those of us who are going to write exams, just note that yes, spastic hemiplegia affects one side of the body, but the upper limbs are more severely affected than the lower limbs. Whilst in spastic diplegia, all four limbs are affected, but the lower limbs are more severely affected, so severely affected that the upper limbs look relatively spared. And so some books will say that in spastic diplegia, only the lower limbs are affected. But the truth is that all four limbs are affected, the upper limbs are relatively spared. Whilst in quadriplegia, all four limbs are affected, sometimes equally affected, but in some instances, the upper limbs again are more severely affected than the lower limbs. Sometimes you may have other forms, like some books will say double hemiplegia. This is when you have the two different insults affecting the two hemispheres separately and giving two different pictures on each side. So most people will say that is a quadriplegia, but because there are two different insults presenting with two different manifestations on the different sides, some will say that is a double hemiplegia. When it comes to spastic hemiplegia, the pathology is usually a focal lesion. But for diplegia, as Dr. McCarthy showed us, it is periventricular leukomalacia. So it is the white matter around the ventricles that are most affected. And I don't want to go into the details of why that is so, but in the preterm infant, they rely more on diffusion and CSF, diffusion through CSF for nourishing of the brain than through vascular distribution. And so spastic diplegia is common in preterm infants. One of the common risk factors for spastic diplegia is prematurity. And then in spastic quadriplegia, we have what we call watershed infants. So these are the terminal ends of the vascular distribution. So you have the anterior cerebral artery territory, or ACA territory, the middle cerebral artery territory, and the posterior cerebral artery territory. These territories do not cross over. So at the extreme ends or at the borders of these territories, perfusion is very low. And so when there is any vascular compromise, it is this end areas that are most severely impacted. And that results in what we call watershed infant. So if you see anything like spastic quadriplegia and watershed infarcts, yes, you can match them. And you can also match spastic diplegia and then periventricular leukomalacia. You can match spastic hemiplegia and focal cortical lesions. The clinical manifestations are as I've listed here. Spastic hemiplegia, they often present with one side manifestation. So they have fisting on the affected side, and then they show early handedness. Most babies, most normally growing babies, will not show handedness until after age 18 to 24 months. So don't be too excited when your newborn baby is telling you they are right-handed or they are left-handed. That may be because they have a problem on the other side. That is why they are demonstrating handedness, but we don't expect handedness to be shown before age 1 year. So when you see early handedness before age 1 year, be worried and look at the other side and see if there is a problem on that other side. When these spastic hemiplegia, they are the most likely to walk, most likely of all the causes of cerebral palsy, or of all the types of cerebral palsy, they are the ones who are most likely to attain independent walking. But they tend to walk with tiptoeing on the affected side. And seizures are quite common, up to about 50%, or 50 to 60% of the patients may have seizures. Spastic diplegia, as I said earlier on, most common seen in patients who suffer hypoxic ischemic injury as a preterm. So most common seen in preterm. And the pathology is periventricular leukomalacia. These ones are very sociable. So they have an alert face. They are very sociable. Their hands are open. They don't show fisting. Remember I said that the upper limbs are relatively spared. So they don't show any fisting. And usually they do not have seizures. But they are very bright. And so to move around, they have severe weakness in their lower limbs. To move around, they use maneuvers like commando crawling or bottom shuffling, or sometimes rolling over to move around. Remember, again, these are normal variants in some infants. So don't go about saying any infant that is commando crawling or bottom shuffling has spastic diplegia. But I'm saying that some spastic diplegias will rely on these maneuvers to move around. When you pull them to stand, or when you hold them up, they demonstrate a scissoring gaze in the lower limbs. The lower limbs tend to cross over. And that is because they have very strong hip adductors, and they have spasticity or increased tone in the hip adductors. And because of that, the lower limbs tend to cross over. And for that same reason, they are also at increased risks of hip subluxation. With the spastic quadriplegias, which is the worst form of cerebral palsy, if you are ever asked to choose one for yourself, stay away from spastic quadriplegia. It is the worst form of cerebral palsy. They have the most severe neurodisability. They have poor socialization. They are delayed development. All of them tend to have delayed development, but the quadriplegias have a very profound delayed development, poor neck control. They tend to have cortical fisting in both hands. They have microcephaly, and then they have bulbar or suprabulbar weakness that will present with dysphagia and dysarthria, and because of that, they have a lot of drooling. They are also the ones that have cortical visual impairment, very poor focusing and following with the eyes. Seizures are common in the spastic quadriplegias, and they have severe intellectual disability. The other form of cerebral palsy after the spastic cerebral palsy is the dyskinetic cerebral palsy. These are also called extrapyramidal, or some books will say athetoid or chorioathetoid cerebral palsy. And the most common etiologies are kernicterus leading to bilirubin-induced neurological dysfunction, or sometimes when you have sudden hypoxic ischemic episodes, as would occur in placenta abruptio or uterine rupture. And the pathology here is that there is damage to the extrapyramidal system or to the basal ganglia. So when we say the extrapyramidal, we are talking about the basal ganglia. And because the basal ganglia controls movements, so these ones have abnormal movement. That is why the term dyskinetic cerebral palsy. The early manifestations, because when you hear dyskinesia or dyskinetic cerebral palsy, everyone is looking for abnormal movement. But in the first 2 years of life, they tend to have no abnormal movement. They don't have any chorioathetosis in the first 2 years of life. What they tend to have as they grow older is more of dystonia. Dystonia is when you have twisting and turning movement on purposeful movement of the limbs. So you see that they have twisting movement when they move their limbs. That is dystonia. In the early stages, they are often hypotonic, and sometimes they will also present with fluctuating muscle tone. They have delayed motor milestones, and then poor neck control. They are the ones who are at risk of sensorineural deafness most of the time. but they have normal socialization if they don't have sensorineural deafness. Late manifestations will include abnormal movement, especially dystonia, much more than chorioathetosis. And the distribution is symmetrical. So when you see any child with abnormal movement on one side, don't be too quick to say that is this kinetic cerebral palsy, because they tend to have symmetrical distribution. Then they have very poorly developed teeth. We call that dental enamel hypoplasia or dysplasia. And the teeth sometimes actually break off. And you can see that, I'm sure most of you are saying that, yes, you've seen patients who had severe neonatal jaundice come to your clinic with very poorly developed teeth. They have difficulty with speech. Swallowing is also difficult. And because of that, they tend to drool a lot. The reason behind the drooling is not because they are producing too much saliva. We all produce saliva, we swallow, and that is why we don't drool. But these ones produce the normal saliva we all do, but they do not, they have difficulty with swallowing. So they pull the secretions in their mouth, and their only way out for the secretions to get out is for them to drool. I think someone called Ernest is writing on the screen. If you can desist from that, we'll be very happy. Patients with this kinetic cerebral palsy may or may not walk independently, and then their intelligence can be normal, and seizures are not common. Then there is a very rare type known as atasic cerebral palsy. They form less than 2% of all cases of cerebral palsy. I have seen only 2 or 3, so it tells you how rare they are. These ones are because of damage to the cerebellum. And you know the cerebellum is for balance and deep perception. Because of that, they have problems with balance and unsteady gait. And they also have difficulty with movement requiring lot of control, such as writing. And they may have decreased or increased muscle tone. But as I said, they are not very common. Again, this is common. The type we call the mixed cerebral palsy. So patients with mixed cerebral palsy have more than one type of cerebral palsy. So it may be a combination of spastic and dyskinesia, or spastic and ataxia, or dyskinesia and ataxia. So that is in various combinations, and we call that mixed type of cerebral palsy. But the most common type of the mixture is when they have spasticity and dyskinesia. And this is because different parts of the brain are affected. So this diagram again shows us, it's a summary of all that I've talked about. We have cerebral palsy. The 4 main types are spastic cerebral palsy, where the injury is to the cortex. Then the dyskinetic cerebral palsy, where the injury is to the basal ganglia. The atasic cerebral palsy, where the injury is to the cerebellum. And then the mixed cerebral palsy, where the injury is to different parts of the brain. When it comes to the spastic cerebral palsy, we talk of the hemiplegic cerebral palsy, where the injury is on one side of the cortex or focal pathology. Then the diplegic cerebral palsy, the injury is usually in the midline, periventricular, around the ventricles. And then the quadriplegic cerebral palsy, they have widespread injury in both hemispheres. And then for the dyskinetic cerebral palsy, remember the injury is to the basal ganglia. So patients with cerebral palsy, even though have primarily motor and movement posture problems, or movement and posture problems, they tend to have a lot of other problems, and we call those other problems comorbidities. So they will have their spasticity, they will have their movement disorders and all that, but they have other problems that we call comorbidities. And this will include developmental delays of various forms. Seizures are common, especially in the quadriplegics, and then also in the hemiplegics. And then they may have visual abnormalities. These include cortical visual impairments. So sometimes you see that they have poor fixing and focusing. You send them to ophthalmology and they will tell you that the eyes are fine. So that is because the brains are not fine. The eyes will see all that needs to be seen, but the brain refuses to interpret them for the patient. So the patient is looking, but it's as if he's not seeing. He's seeing all right, but the brain is not interpreting. So we say it is visual impairment or blindness that is coming from the cortex. That is why the term cortical blindness or cortical visual impairment. Some of them will have disorders of ocular motility, squints, refractive errors, and then optic atrophy. They may also have hearing impairment, especially those that have dyskinetic cerebral palsy dyskinetic cerebral palsy. They may have hearing impairment, speech defects because of poor articulation, and then the suprabulbar or bulbar palsies will lead to speech defects. Intellectual or learning disabilities are common, especially in the quadriplegics, because the cortex, especially the frontal lobe, which is responsible for learning and executive function, has been affected.
I think we may have lost Dr. Hammond. Please give us a few minutes. I'm sure he'll come back. Charles, you're muted.
Hello, can you hear me now?
Yes, we can hear you.
I think I went off.
Yeah.
Sorry about that. That was internet connectivity. I don't know
Okay.
where I went off.
When
I was talking about comorbidities, right?
Yes.
So probably on this slide.
I think we can continue from there.
Yes. So I said that they have feeding problems, and that is because of poor swallowing. And some parents will force feed them because sometimes it takes a long time to finish a cup of porridge. It might take even 30 minutes to finish a cup of porridge. So if we don't educate this parent, they think the children are just being lazy with swallowing, and they force feed them, hold their nostrils and force them to swallow. And in doing so, they aspirate, and they come to hospital with aspiration pneumonia. And that is one of the most common causes of death for babies with cerebral palsy. Aspiration pneumonia is one of the most common causes, one of the most common reasons they succumb to the condition. A lot of them also have gastroesophageal reflux. It is very difficult to tell that they are having gastroesophageal reflux. And so for most of the time, you have to do some tests, check for the acidity of the esophageal contents. But because you are not able to do it in most parts of our world, we have to assume, especially when they come with persistent action of the back, we have to assume that they have gastroesophageal reflux and treat. This gastroesophageal reflux could also be responsible for micro aspirations. They reflux and then they aspirate. And then gait abnormalities, we've talked about that already. Contractures are common, hip subluxation, especially in spastic diplegia. And then because of all the problems they have, they become objects of abuse and neglect. I can imagine a frustrated mother who has to quit her job, or she may be doing petty trading on the street, but because of this child with cerebral palsy, she's not able to put this child in school, or most schools will not accept this child. So she has to quit her job to take care of this child. So that actually sets a cycle of disease, poverty, and then ignorance, and then it goes round and round and round. And these children become objects of abuse or subjects of abuse and neglect, and then they lead to failure to thrive, also because of the challenges with feeding. And as they grow older, now they are growing older. As they grow older, they have behavior and emotional problems because, yes, they get to adolescent age and then they have a lot of questions. Why am I the only one different in my class? And then sometimes to get validation, they would just then do terrible things. Behavior issues, drugs, experimentation with drugs and sex and other things, just for validation. And so conditions like depression, attention deficit and hyperactivity disorder, and then sometimes even autism spectrum disorder are common in patients with cerebral palsy. I want to talk about diagnosis, and then we'll talk about management in the next few slides. The diagnosis is clinical. There is nothing like a test or some neuroimaging that you would do to make a diagnosis of cerebral palsy. It is a clinical diagnosis. Based on your history, your examination findings, you can always say, I've made a diagnosis of cerebral palsy. So you only do special investigations to help you determine sometimes the etiology, the risk factors that were involved, the timing of the insult, and then to exclude differential diagnosis. And then sometimes to help you identify comorbidities. These are the reasons you would do special investigations. And common investigations will include ultrasound, transfontanel ultrasound. This can be used in babies whose anterior fontanels are still patent. And it might help you pick up things like bleeds, especially in the preterm infants, because intraventricular bleeding is a common cause of cerebral palsy. For the older children, you want to do a CT or an MRI, but you have to avoid the CT scan in the child under age 1 because of the harmful effects of the radiation. So MRI is always preferred, but then it is more difficult to achieve. In our part of the world, we don't have MRI in many places. And then even in places where you have the MRI, because these children will require anesthesia, and so it's not so easy to get it done. And so it becomes more expensive to do MRI for them. There are some features that when you see, you should think of other conditions rather than cerebral palsy. When you see an abnormally increasing hair circumference, you should think of hydrocephalus, think of tumors, think of white matter disease or what we call leukodystrophies, rather than cerebral palsy. So that will tell you there's something progressive going on. But cerebral palsy is non-progressive, remember. If you see eye abnormalities like cataracts, retinal pigmentary changes, when you send to the eye ophthalmology and they tell you that there are pigmentary changes on the retina, also be worried. Think of neurodegenerative disease, think of Story disease and others. When you see skin abnormalities like hypopigmentation or hyperpigmentations like cafe au lait spots and others, think of neurocutaneous syndromes. That may not be cerebral palsy, so you have to think of neurocutaneous syndromes. When you see organomegalies, because like splenomegaly, hepatomegaly, think of Story diseases. Or in our part of the world, it's important to also think of infectious disease or infectious causes. Sensory abnormalities, especially when it's purely sensory, may also point to other conditions rather than cerebral palsy. I think this is where most of us want to hear. This is what most of us want to hear. How do we manage the child with cerebral palsy? The aim of your management will be to maximize their mobility. Because remember, it is a movement and posture problem. So you want to correct their posture, you want to maximize their mobility, and that is where physical therapy becomes very, very important. And then you may use assistive devices like splints, walkers, wheelchairs, and etc. Speech and occupational therapy are important, not because we want them to speak, but because we want them to learn some basic requirements for daily living. Speech therapy is fine for speaking, but that is not the primary duty of speech therapy. Speech therapy actually looks at the safety of swallowing and then helps us to feed them properly to avoid all the problems with swallowing. And then it also helps with communication. Occupational therapy is very important, and we should, if we do not have occupational therapists in our hospitals, we should push that the ministry post people with occupational therapy in our hospitals. Most of these administrators do not know the essence of the therapy, so they might think that occupational therapy is physiotherapy of the hand. It's far more than that. They actually help with activities of daily living. So these children with developmental issues are taught or are trained to cope and then to be able to live with their their disabilities, use how best they can use their potentials to express themselves and then to also cope with activities of daily living. We may send them to surgery for various reasons, sometimes to correct abnormalities like squints, tendon adhesions, hip subluxation, spasticity, and others. These are the reasons we might send them to surgery. Today, I had another patient in clinic who told me he has withdrawn his child from school. And I said, why don't you go back to school? Because the child has cerebral palsy, has seizures. And the reason is that he's tried 2 different schools and they are not accepting the child. That is the problem we have. It is so stigmatized that no one wants to accept the child in their school. In fact, the child is stigmatized. When you come to even the hospital, those of us who take care of patients with cerebral palsy, we are also stigmatized. Okay, some time ago, a colleague told me that you and your mad patients, that is stigmatization. I think we are also stigmatized. It's unfortunate, but because we are part of the bigger society. So we bring our beliefs and our myths and misconceptions from home to work. But with more education, I think that we should be able to overcome that. The most important thing is to help the young child with cerebral palsy attain their full potential. Having said all this, it is important that we adopt a multidisciplinary approach. So you see that one person cannot sit in the consulting room and manage the patient with cerebral palsy. It is very, very important that we adopt a multidisciplinary approach. And I always say that that is where various specialties come together to manage one child, because the child will come with a package of problems, and no one person can manage all of them. But there should be someone who is coordinating the care, someone in the center of this multidisciplinary approach. And that is always in places where they have a lot of developmental pediatricians, that will be the developmental pediatrician in the center of the care of the child with cerebral palsy. In Ghana, I am happy to say that a pediatrician or an experienced medical practitioner, even a family physician, can be in the center to coordinate the care of the child with cerebral palsy. So this person takes primary responsibility for the care of this patient, but sends them to various disciplines, and then they go and they come back. So you send them to audiology, they go and get their ear tested, and then they come back to you with a report. You send them to speech therapy, they go and come back. You send them to physical therapy or physiotherapy, to occupational therapy, to neurologists, to ophthalmologists, orthopedic surgeon for tendon release, and then conditions like hip subluxation, to the neurosurgeons if there are any things that need to be done either on the spine or in the brain. I will talk about that later on. The dietitian is very important. We remember me talking about failure to thrive. So the dietitian has to be on board. The clinical psychologist is needed right from the beginning. In the early stages for the parents who need a lot of psychological support. But as the child grows older, for the child himself also, who will have a lot of questions on their mind. And if we don't provide, we should anticipate these things and then provide support for them. And then we need specialist teachers, like the one I talked about today, who has been turned away from 2 schools. If the schools had specialist teachers, they would be able to accept and admit this child. The social worker is very, very important. We cannot function without the social worker. But let's also remember that the parents or the caregivers are part of the multidisciplinary team. So we don't take decisions without their involvement. They are key stakeholders and actually the most important members of the multidisciplinary team. So to end, I want to talk about some, I think Dr. McCarthy did a fantastic job talking about preventive strategies for cerebral palsy. And I took a lot of notes myself. I just want to add these 2 current innovations. One of them is systemic hypothermia, where they cool the body, especially for patients who have suffered hypoxic ischemic encephalopathy. So they cool the body Some people will do whole body cooling, some will do only head cooling. They cool it to very low temperatures for a prolonged time. And this decreases the rate of cell death, the rate of neuronal death, and then it prevents disability from brain injury. So it is working very well. We do not have it in our country at the moment, but we should position ourselves for it. And most of our neonatologists will begin to take this up soon, I'm sure. And then we will have most of our babies being cooled. So therapeutic hypothermia is something that has been shown to be very effective in treating neurologic symptoms in babies with hypoxic ischemic encephalopathy. And I think we should begin to move towards that. Then there is the big area of stem cell therapy, which is not available to us here, yes. It is still, even in the Western world, it is still being investigated. So it is currently experimental. We see a lot of patients crisscrossing continents. I've had several patients come to me and say they want to go to India to do stem cell therapy. A lot of them have been to India, but when they come, you don't really see the benefits of what they did. So I will say that let us not be in a hurry to send our patients to India. Let's use the resources they have to support the children until these innovations become established and we know for sure that they are beneficial. But the few that I have seen, they have come back with no clear benefits from going to India and wasting a lot of money. Yeah, so it is still being investigated. And the idea behind it is that stem cells are capable of regenerating into neuronal cells. You know, the neuron is not able to repair itself and it's not able to regenerate itself. When you have a lesion on any part of your body or any organ, it repairs itself, but the brain doesn't. So we are born with about 80 million brain cells. And as we grow older, some will be dying and dying and dying until you are 100 years, and then you've lost a lot of your brain cells. And when you have eaten in the morning, you have even forgotten that you have eaten. You say you have not eaten the whole year. So that is, dementia is mainly because you have lost your brain cells. So because that is because the brain is not repairing itself. But what people are saying is that, or what scientists are saying is that stem cells are capable of regenerating into brain tissue. So they are beginning to use stem cells, and they are specifically using umbilical cord blood cells, infusing it into the patient to see if they will have some improvement, especially for patients who have suffered severe brain insults. So that is what is being done. But as I said, it is experimental, and we should be in a hurry to send our patients to go and get stem cell therapy. The prognosis, this is my last slide, of cerebral palsy is depends on where you are in the world. Remember that it is not a progressive condition. So living into old age is possible. And some may have worsening of long-term symptoms, but that is not very characteristic, or regression of symptoms. That's not very characteristic. Rather, they improve, but they improve slowly. And as I said, prognosis varies according to the severity and according to your geographical location. The lifespan is usually reduced by complications such as reduced mobility, feeding difficulties, respiratory infections, epilepsy, etc., etc. Yes, I must tell you that I have patients with cerebral palsy who are currently in the university. So when we give them the right kind of support, they can go far. So even today, I saw one of my patients who is currently a level 400 student in the University of Ghana. So yes, so if we give them the necessary support, they can grow into adult life. In the US, as of 2008, the average lifespan for patients with cerebral palsy was 35 years. Unfortunately, we don't have data for Ghana, but what we know is that most of them die very early in early childhood. Yeah, they die in early childhood, and that is unfortunate. So we have to work together to change the narrative. this will be the end of my presentation. I guess Dr. Mabel will take over from here. Thank you.
Thank you. Thank you very much, Dr. McCarthy. Thank you very much, Dr. Hammond. There are lots of messages in the chat box, and people have really appreciated it. I must say that we had a full house today. There were 500 people, and they couldn't get space, so we were also live on our YouTube. And I believe most of us here are health professionals. So this is a very big step for us. If almost 500 plus health professionals are listening to this and getting educated, I hope you are going to take this. So before I look for we start question answers. I know we invited some of our parents here, and this has been pretty technical. So let me just summarize for them 30 seconds what I learned. And every time I listen to this topic, I learn something new. So there's always, there's always information. So mainly, we talked about preventive methods and strategies to reduce the prevalence of cerebral palsy. Dr. McCarthy talked about things like using magnesium sulfate during pregnancy in certain conditions, using antenatal steroids, treating infections, mothers getting vaccinated, mothers making sure that they are healthy and not taking poisonous substances like alcohol, tobacco, and hardcore drugs during pregnancy. Whatever you can do to preserve the baby in your womb in the pristine, ideal conditions that they need till term, till the 37 weeks plus, we need to do it. Dr. Hammond has also given us an extensive presentation on the causes and especially the management of cerebral palsy. And indeed, I'm also quite sad because last week I lost one of my clients who had cerebral palsy. And we don't see a lot of these children growing up into adulthood. And we hope that as we continue to create awareness and improve our management, especially things like systemic hypothermia for those with birth asphyxia, I'm hoping that the outcomes will be excellent and great for our children and individuals with cerebral palsy. So let's now go for questions. I haven't seen any questions yet. But I think I saw somebody. Okay, there are some of my parents here saying hi. Okay. The comments are all great, very educational, very resourceful. Okay, yes, I've seen some questions. Okay. So let me start with a comment that says, very informative, but I think we need to counsel our midwives to avoid boxing everyone under a radiant warmer, especially for those with birth asphyxia. Okay, so this is a contribution and a comment by somebody on the page. So this question says, would like to know if micronutrients with DHA helps preterms or term babies with moderate to severe HIE. If it helps, how soon can it be started and how does it improve functioning, preventing progress of brain injury? I think I shall give that to Dr. Hammond.
Yes, thank you very much. So this is one of the very topical things that is currently being discussed. We know that in the laboratories and also in laboratory animals like rats and mice, DHAs play a very important role in their brain development. And so we extrapolate that to humans, and we say that, yes, it does play a role again in brain development. So most of our patients will ask for DHAs to be given. But I mean, the point is that the insults have happened already. And so yeah, we do give DHA sometimes, but in my personal opinion, I don't think they repair the damage. So they are good for brain development, yes, but they may not repair the damage. And it's not only children with cerebral palsies who need the DHAs or the micronutrients. All children do. And most of them get these micronutrients in their regular foods anyway. But as a supplement for any child with a brain insult, that is fine. I mean, as long as it is not harmful, I am happy to prescribe it. But I don't want to say that it will fix the problem. It usually will not fix the problem.
Thank you. Thank you. So to add to that, the person asked about when to start. So definitely, since it's not going to fix the problem, our breastfeeding, exclusive breastfeeding for the first 6 months of life should be remembered. So if you're going to add any micronutrients, please start when the child is weaned after 6 months. Thank you very much. The next question, I think, is for Dr. McCarthy. It says that, hello, please. I heard something about naphthalene balls in the first presentation. Can you talk about that again?
Right.
Yeah.
Right. I would like to add a comment to Dr. Hammond's DHA for the needs. For the pregnant women, we're actually advocating them having DHA from early pregnancy as part of their prenatal vitamins for the brain development of the fetus. So maybe that is the time to apply the DHA rather than after the damage has been caused. So we are advocating for DHA as part of the antenatal vitamins. The naphthalene balls, I was talking about naphthalene balls in relation to neonatal jaundice in a patient that had G6PD deficiency, the child. And this is a problem. We even have this problem with pregnant women who have persistent anemia, and then they have G6PD, and they are using the naphthalene balls at home, in their cupboards, in their wardrobes, among their clothes, in their bathrooms, and so on. And so that then causes hemolysis of the G6PD patient, and so she then has persistent anemia. And this can also happen in the neonate if the cord sheets and the various things that are used for the baby in clothing and for the bedding are also impregnated, so to speak, with the naphthalene balls. And so knowing the G6PD status of the parents is important because the children can also have that. I don't know, how early are we testing G6PD for the children? Is it after 6 months or right early? I don't know the answer to that. But
G6PD screening can be done right at
anytime.
birth.
So right at birth. So I think that's part of the newborn screening that we are doing now.
Yeah.
Yeah. So that's the naphthalene balls issue.
Okay. So whilst we have you, could you answer this next one about hypothyroidism? Somebody heard you talk about thyroid in pregnancy, and they can't figure out what the link is with cerebral palsy.
So the link is you want to find anything that can cause a preterm delivery. And so any of the factors that can cause a preterm delivery, you'd want to eliminate. And so you'd want to optimize your chronic conditions before you start your pregnancy. And so if you have a thyroid disease, you want to optimize that before you start your pregnancy. And so maybe, they are usually, those who have had the thyroid surgery are usually put on thyroxine supplementation orally. and they get tired of the medication, so they stop. But if you are going to start a pregnancy, then you need to be back on that medication to optimize your thyroid function.
Thank you. Thank you very much. Dr. Hammond, there's a student counselor who wants to know how he can be of benefit to the cerebral palsy community. I think that is what his question or comment is. What can he do? Dr. Hammond, are you there? Oh, I think he can't hear me. Charles. Okay, let me continue. Then there was a comment about inclusivity. I think that's from Dr. Daniel. What about the inclusivity drive for our schools that should help stimulate our children with cerebral palsy? Yes, indeed. That is the main aim of the inclusive policy for the Ghana Education Service, that every child, no matter their ability or disability, should be able to go to school in their community school. So as usual for Ghana, it is a policy. However, the implementation has quite a bit to go. So no school is supposed to turn you away. However, some schools will say they do not have the resources to be able to take the children. And if you as a parent can see indeed they don't have the resources and they are going to neglect your child, then it's usually better to find a different place. I think we lost Dr. Hammond, but we shall continue. Okay. Oh, Dr. Hammond, you're back. Okay, and you're muted. Okay. Okay, so Charles, can you hear me? Okay, but you're muted. Can you unmute yourself? Okay. Maybe the host has to unmute you. Okay, you're a co-host now, so I think you can unmute yourself. So the question was, a student counselor was wondering what they could do with to help the cerebral palsy community. He said, how can you link cerebral palsy to counseling? Please help. I'm a student counselor. I want benefits. I'm not sure what that means.
Yes, I mean, we need everyone on board, and especially people with some form of knowledge on what cerebral palsy is. So we need everyone on board to help. And so I will say that we should be able to start to form parent support groups and also be able to help our parents in various forms. These people have all sorts of beliefs and they do all manner of things. I mean, I've seen so many patients doing different things and all manner of things. And so they need a lot of counseling. So we need counselors on board. We need social workers on board. I think I mentioned psychosocial supports as part of the multidisciplinary group. And that is where the counselors really come in. You must be on board to counsel the parents. Some of them carry guilt. They think the child is suffering because of something they did wrong. Some think the child is suffering because of some sins they might have committed. In some communities, they think some ancestors may have done something bad. Some, especially in Akans, I'm in Kumasi, so I'm very familiar with what the Ashantis would do. They have a disease they call asram, and they think an evil eye has been set on the child, and so they will do all sorts of things, including scarifications, including bathing the child with some dangerous things, and then doing all manner of things. So counseling is very, very important for them to appreciate that this is a condition that resulted from an unfortunate insult or injury to the brain. And then for them to also appreciate what can be done, because some of them spend large sums of money buying goat and cattle and lizard and other things for spiritual and herbal practitioners to cast out the disease. And these things do not work. But we need a lot of talking, a lot of counseling, a lot of teaching for us to get these things right with the parents. As the child is growing, as I said, especially when they get to adolescent age, they have a lot of questions on their mind. And so a lot of counseling must again come in. And these are where we need counselors. But we should begin to form patient support groups so that we can bring them together, and then they themselves become counselors also. Some of them become counselors. And then as our patients also grow, we should form patient support groups so that they are also able to help each other with coping mechanisms and strategies. So that would be my answer to that question.
Thank
Over.
you. Thank you. Thank you very much. Now the questions are coming. I hope we'll be able to touch on most before we leave, before 8 o'clock. So there's a question, Dr. McCarthy. I think this person was either a late comer. No, the person said their internet wasn't too good, but they would like just a brief summary from the obstetrician point of view about the management to help with prevention. So just like 2 or 3 lines, please.
Yes, yes, of course. So the prevention has to do with the preconception interventions, looking at the history and counseling, then looking at the obstetric history to avoid things like preterm labor, and know whether they needed assisted vaginal deliveries and had a previous low APGAR score or stillbirth. Reviewing the maternal history, diabetes, hypertension, thyroid disorders, and so on. And then also looking at the immunization and the travel plans of the patient. And then in the antenatal time, full and regular antenatal care. I think this message has been very, very strong. And then during the antenatal care, monitoring the fetus really well, looking for placenta resistance, looking at the growth, timely intervention for fetal distress. And when you see something, a timely intervention of that. I think somebody asked about the relationship of increased amniotic fluid and how that was working. And that has to do with preterm delivery again, because once there is hyperdistension of the uterus, then preterm labor could actually start. And then looking at detecting and managing drug abuse, alcohol ingestion, cigarette, including secondhand cigarette smoking. Now there's a lot of shisha and all those things going on. So you ask, do you smoke? She says, no, I don't smoke. I only do shisha. And then that's a problem. And so they may think that it's normal or safe in pregnancy. In the antenatal section. Then we talk about the interventions within labor. You want to monitor the labor very well using the various methods to avoid abnormal heart rates and so on. Timely intervention. Sometimes a vacuum delivery is needed at the right time to avoid a cesarean delivery. Or an emergency cesarean delivery done at the right time to avoid obstructed labor or damage or hypoxia to the patient. And then I talked specifically about some of the interventions to prevent preterm labor and to optimize the outcome and prevent preterm deliveries or give a better outcome. Magnesium sulfate for neuroprotection, antenatal corticosteroids for lung maturation and prevention of complications, tocolysis with magnesium sulfate or nifedipine, prophylactic use of progesterone supplementation, and that is vaginal suppositories of progesterone to prevent preterm labor, and also prophylactic and emergency cervical cerclage. Also to address infectious issues with antibiotics in PPROM, and also to detect maternal hyperpyrexia. Finally, I think was post-delivery. Did I say anything about post-delivery? Yes, to talk about post-delivery, optimizing how they are resuscitated, proper training in resuscitation, timely resuscitation, avoiding hypoxia in that first minute, first 5 minutes, first hour, and so on. Appropriate NICU admission when needed, and so on. I think basically those are the things we spoke about. We got also into the neonatal jaundice, which could then be a problem, and the neuroprotective interventions. So, in summary.
Excellent. 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 Thank you very much. I'm praying for the day that the obstetricians will find a way to prevent preterm delivery in total. That will be the day.
Oh, that
It
one
will
is family planning. It's contraception.
That
We have
will
already
really
got a
help us.
solution for you. We've got a solution, family planning. If there are no
Okay.
pregnancies, then we can prevent it.
Well, preterm delivery. So there's been a question about supportive group. I don't know in Kumasi, but in Accra, there's a parent support group association. However, they are, I think, mainly only on WhatsApp. I don't think they meet physically, but at least they help themselves. Dr. Hammond, is there any support group in Kumasi?
Yes, we started one.
Okay.
I am actually on their WhatsApp page. I don't contribute. I'm only an observer on the page, but the page is very dormant. They only put up messages when somebody has shit off for sale or something.
I see.
Yes,
Okay.
and it's like once in a month where you see a message, and
Yeah.
the reason it has not been very active is we had a nurse who was organizing it. So the nurse brought them together, and they had their own elections. They had their president, secretary, treasurer, etc.
Yeah.
With time, then the nurse actually relocated out of the country. So there's no person actually organizing it now. So I've assigned another nurse to be there to organize. Yes. And then what I also see is that they are a very I mean, the turnover rate is very high. They come into the group and they exit, and they come into a group and exit. So you always have new people, and then it becomes a platform for selling shit or instead of talking cerebral palsy. But then there is, yes, we can reorganize ourselves and revamp it. Yeah.
Okay. I must say that when it comes to support groups, the ones I see thriving are the ones that are being organized by parents, and the parents have a buy-in. But if the parents don't have a buy-in and they're expecting the other professionals to keep it going, most of the time it dies off. Okay.
Absolutely.
All right. Okay, thank you. I think we'll have to be wrapping up now. There's been two questions about genetic. Is there a genetic basis for cerebral palsy? Charles, if you can just give like a two-line
So
for
yeah, so
that.
I talked about when I talked about preconceptional risk factors, I said that when there are some genetic bases. So genetic basis, technically, if you look, you will not say because they have an insult to the developing brain, because these are things that are existing even before the baby is conceived, but they predispose the baby to insults. So some deletions and micro deletions will lead to some conditions that will let the baby have a malformed brain, for example, and that will become cerebral palsy. Some academicians will maybe separate these ones from cerebral palsy proper, but some also say that genetics or genes play about 2% role in contributing to the risk factors of cerebral palsy. So if you look at all the risk factors of cerebral palsy, they are saying that 2% of them are from genes or genetic causes. Yeah.
Okay, thank you very much. So as we wrap up, there's an evaluation form on the chat, in the chat page. Please look for it and fill the evaluation form for us to give us feedback as to how these virtual lectures go so we can do better. Um, there are two questions about management. Somebody is asking if the role of physical therapy in management of cerebral palsy. That person may have joined us later on, so didn't hear that part. Somebody is also asking about the role of muscle relaxants and anti-spasticity medications, if they are effective. And let me add the third one. Somebody is also asking about neuroprotection for neonates when they are born with birth asphyxia. Is there any medication for that?
Okay, so let me start with the first one, which is it the anti-spasmodics and muscle
Yes,
relaxants? Yes,
yes,
so these are a mainstay of management for us, mainstay of management, because I didn't talk about the management of spasticity,
yeah,
but it's the main drug we use when we are managing spasticity. So most of our patients are using drugs like baclofen to relax them, because the spasticity, we don't hear from our patients. They don't talk, but if they talk, they will tell you that the muscle contractions are painful. You put your elbow in a contracted position continuously for 5 minutes and see how you feel. It's painful. We need to relax them. So I'm very generous with baclofen.
yeah,
For some of them, I even go beyond baclofen. You can relax them with diazepam. Yes, you can use diazepam. Then you can use other medications like benhezol, attain, to decrease the abnormal movement. So we do a lot of muscle relaxants for muscle relaxation. I think we should be generous with that. It doesn't hurt if you give them diazepam and they sleep for prolonged periods. I mean, the most important thing is that you prevent their pain. And someone talked about what medications we use for neuroprotection, or what do we do for neuroprotection. So neuroprotection is basically the steps that you take in protecting the brain that has already suffered an insult from getting worse. So things like oxygen supplementation is very important. Correcting hypoglycemia is very important. Preventing seizures. And so again, if you work in a neonatal unit, you must have phenobarbital handy, because you need to prevent seizures. And then you must have a high index for, or a very low index for, what do you call it? Hypoglycemia. So any baby that you think is probably not, is sick. I mean, one of the most common things sick babies do is they go into hypoglycemia, irrespective of what their condition is. So most babies, when they are sick, they go into hypoglycemia. This is because the glycogen stores in the liver are very low or non-existent at all. So the slightest trigger, they go into hypoglycemia. So we should always be checking their blood sugars and correct hypoglycemia. That is neuroprotective. Oxygen is important, but don't overdo it, because if you give too much oxygen to the preterm baby, you may also cause damage to their eyes. And then also prevent seizures as much as possible. Proper fluid for proper circulation is also good. Don't overdo it, because the fluids might accumulate in the lungs and become a problem for the babies as they breathe. Anemia is one thing that must be avoided. And if it is present, it should be corrected as soon as possible. That is also neuroprotective. So you make sure that the brain gets adequate substrates. Include the substrate here, include oxygen and glucose. And then also there should be a quick way of taking out toxic metabolites so that they do not accumulate in the brain. That is the whole concept of neuroprotection. I think the last question was the role of physiotherapy. You said the person might have joined late, but it plays a very, very, very big role in managing the child with cerebral palsy. There cannot be proper management of cerebral palsy without physiotherapy. It is so key. Yeah.
Thank you. Thank you. So there's somebody offering in Kumasi who wants to help with the support group. She's called Jacqueline. Jacqueline, please send a message directly to Dr. Hammond,
That
Jacqueline
would be very
Teria,
good.
so that he
Thank you.
can link you up with the parents to help. Somebody also sent a message about how difficult it is for parents to find neurologists to help with the management of children with CP. As Dr. Hammond said, unfortunately, we don't have a lot of pediatric neurologists in Ghana. And so any pediatrician or any experienced doctor who works with children can be your first point of call. So wherever you are, please look for an experienced pediatrician to help you. I think I'll take my last two questions. Somebody asked Dr. Hammond, that's okay. So Dr. Hammond has put his number there. Dr. Hammond, you'll be inundated with calls and messages.
That's fine.
Somebody asked the link about stillbirths. And so Jacqueline is a nurse. Excellent. So somebody asked a question about stillbirths. You mentioned something about stillbirths being a risk factor for birth asphyxia, and they want to know what the link is.
So they may not be a direct link, but we are saying that when a mother has lost a baby, a previous baby, there is always a risk that another baby could follow along the same line, especially when there are, or when the risk factors still remain persistent. Whatever caused the first loss, if it still persists, then there is a likelihood that another baby could go along the same line.
Okay.
So yes, as you heard Dr. McCarthy also say, even artificial or in vitro fertilization and things like that are becoming very common now, and they are all associated with higher risk for having babies with cerebral palsy. That is not a direct link. That is kind of indirect. But with the stillbirths, what I can say is that it's mainly because the risk factor which led to the stillbirth is still there.
Yeah.
So you can subsequently have another child. For example, if you have a child born at 26 weeks and the child dies at 26 weeks, okay, then your obstetrician, or you've had two children, all of them dying at 26 weeks, then your obstetrician will say that for this one, I will take the baby out at 25 weeks. This baby has preterm. That is of a risk factor for developing cerebral palsy. So that is how I can link them up. Yes, it is not direct link, it's kind of indirect.
Yeah, okay. Thank you very much. It's 8 o'clock now, and we can stay here for hours and hours because there's so much to learn when it comes to cerebral palsy, but we cannot do that. So I'm going to stop answering questions now. For all of you here who have child health at your heart and are child health advocates, please make sure you're part of the Pediatric Society of Ghana. If you are not on our WhatsApp page, please find a way to get onto the page and we can try and answer some of the questions that you still have. Dr. Hammond is there. I'm also there, and I'll channel your questions to Dr. McCarthy. Maybe we have to add him to the PSG page also.
He's now an automatic member. Yes, we want
So,
I should be part so that I can see how to prevent the problems that we are seeing.
Exactly.
We
So
want you badly.
I'm going to add
Very
him to
glad
the
be part.
page. So all the questions we've not been able to answer, please join the page and ask the questions, and we can continue to answer as the weeks go forward. If you haven't filled the evaluation sheet, please make sure that you do that before you leave us. It's really, really important. For those of you who asked for slides, the whole presentation plus the slides are on our YouTube page, PSG YouTube page. The link is in the chat box. You can listen over and over again, and you'll get all the information that you need from there. So we will not be giving you the slides, but you can check the YouTube page and you can see the slides there. Thank you so much, Dr. McCarthy and Dr. Hammond, for giving us this extensive and insightful presentation. I can assure you that we have learned a lot, and we pray and we hope that we can change the status quo and begin something new in Ghana. Thank you
Yes.
very, very much.
Thank you.
Okay.
Bye-bye.
And thank you everybody else for coming. You really made our day. Thank you. Bye.
Right.
Bye.